All right, so today we're going to talk about the diagnostic set of multiple lung nodules, and we'll also discuss cavitary lesions. So if I show you this chest radiograph, so what's the finding on the chest radiograph?
Many nodules.
Yeah, well, what would you say about the nodules? Anything else to say about these nodules?
There's no cavitation.
No, there's no cavitation. So they're well circumscribed, smooth nodules, right? So what is your differential diagnosis?
Mets.
All right, so the first thought is going to be metastatic disease. Is there anything else this could be except metastatic disease? Is there anything else that might give you multiple nodules besides metastatic disease? TB, although usually not so well circumscribed, they tend to be smaller. Sarcoid, not this big. No, that's usually not as diffuse. There you might expect to see some cavitation.
Bronchopneumonia?
Bronchopneumonia would have more ill-defined borders.
Maybe septic emboli.
Early septic emboli might, right, before you get cavitation with early septic emboli. Anything else? Fungal infection. Fungal infection can also give you multiple nodules, and with things like histoplasmosis and cryptococcosis, sometimes they can be well circumscribed, okay? But of course, your first thought here is going to be metastatic disease. And what is the finding here on the CT scan in the same patient? Yeah, there's a large retroperitoneal mass, and we have these nodules. So what is your differential diagnosis? How do you put these images together? What could these be? So lymphoma, that could be retroperitoneal lymphadenopathy. So lymphoma can give you, retroperitoneal nodes might give you disease like that in the lungs. Anything else? Yeah, so retroperitoneal tumors, large retroperitoneal tumors, the first one that, most common primary retroperitoneal tumor, especially if it's a large mass, you would think of sarcomas, okay? So it can be any kind of sarcoma, MFH, leiomyosarcoma, right? So those things would be in the differential. Anything else? Well, what if I tell you it's a 25-year-old male? Yeah, this germ cell tumor, this is metastatic germ cell tumor. This is somebody with a seminoma. Right, so it's a germ cell tumor, that's retroperitoneal lymphadenopathy, and what do we call those kind of big round mets in the lung? There's a term for these kind of mets. We call these cannonball metastases, right? So you can see that with sarcomas, you can also see it with germ cell tumors, okay? Another patient with multiple lesions, what's different about these when you look at the appearance of these compared to what you saw before? What looks different? These have what?
Not as well defined.
Yeah, so the borders are not as well defined. What else about the borders? Yeah, there's ground glass. There's a ground glass halo. So what does that suggest? So one possibility is angioinvasive aspergillosis. What do we call the sign? The halo sign. Who gets invasive aspergillosis?
Neutropenia.
What kind of immunocompromise do they have?
Neutropenia.
They're neutropenic, right? So neutropenic patients. What else might give you that appearance of ground glass halos or multiple lesions?
Like an adenocarcinoma?
What?
Adenocarcinoma?
Why would it have a ground glass? Well, if it's lung cancer, right? So we know that lung cancers can be associated with ground glass. So metastatic adenocarcinoma for lung cancer can do that, right? But what's another feature of the neoplasm that might give you ground glass around it? Hemorrhage. So what are hemorrhagic metastases? What tumors can give you hemorrhagic metastases? So you think of vascular tumors, thyroid, renal cell, what else did you mention? Melanoma, choriocarcinoma, right, so in females, choriocarcinoma. So hemorrhagic metastases can also give you ground glass halos. But this was a neutropenic patient, and this was an example of invasive aspergillosis. If I show you this chest radiograph, what are the findings here? There's a pneumothorax, and what else do we have? Yeah. So we have bilateral large parenchymal masses here. Now, assuming that you did not do a lung biopsy on this patient, how do you put the findings together? Of course, you can have a pneumothorax after a lung biopsy, but assuming that no intervention was done, how do you put these findings together?
Like catamenial pneumothorax?
Is catamenial pneumothorax, first of all, is this a male or a female, do you think?
It's male.
Okay, and is catamenial pneumothorax associated with well circumscribed lung nodules? What is catamenial pneumothorax associated with? What do you have in the chest?
It's a pleural.
Yeah, pleural lesions, pleural effusion, right? So we're going to cross that off. So how do you put lung nodules and pneumothorax together? Is there a particular kind of metastatic tumor that's associated with pneumothorax? So,
Osteosarcoma.
yeah, metastatic osteosarcoma, metastatic sarcoma. So this patient had metastatic sarcoma. So especially osteosarcoma is notorious for giving you spontaneous pneumothorax. There's also another feature of sarcomas. Sarcomas can also give you cannonball metastases. Sarcoma mets have a tendency to have very well-defined borders too. You see how clear those borders are with sarcoma metastases. All right. Okay, so we have another case of a person with these ill-defined nodular opacities here. And if I show you these images on the same person, what are we thinking about?
Whereabouts? Like in the soft tissue?
Yeah, so these are in the soft tissues, right? So these are not nodules actually in the lung, even though they look like they might be in the lung when you look at the chest radiograph, right? So these are actually soft tissue nodules. So what do we think about here?
NF.
Neurofibromatosis, right? So neurofibromatosis can give you multiple skin lesions. Sometimes on a chest radiograph, you might mistake that for lung nodules. And indeed here, you can see that you have all of these skin lesions that you can easily mistake for nodules in the lung on a chest radiograph. Patient has another finding also associated with neurofibromatosis. What's that? The lungs look normal? Yeah, you have these cystic changes in the lung, so it's a rare manifestation, but that can also be associated with neurofibromatosis. Okay? So when we're dealing with multiple lung nodules, in most cases, it's going to be metastatic disease, especially carcinoma, any carcinomas from anywhere. Sarcoma mets can be associated with pneumothorax, especially osteosarcoma. Other unusual, inflammatory lesions can give you multiple nodules. Infection, TB, fungal infections can also give you multiple nodules. There are some rare causes of multiple nodules, and of course, pseudonodules we can also see with skin lesions. Okay. Here, the characteristic finding is you have a large cavitary lesion with an air fluid. Do you think this is benign or malignant? Why do you think it's malignant? So it has very thick walls, right? So the thicker the wall, the more you're going to be concerned about malignancy. So what kind of malignancy do you think this was? Yeah, this was a primary squamous cell cancer in the lung. Okay, so you have look where the wall is thickest. You have a very thick wall, cavitary lesion, and we know that squamous cell cancers are associated with cavitary lesions. Okay, so the finding in this patient is what? Yeah, so we have multiple lesions here, some of which are cavitary. What's your differential diagnosis here? So septic emboli might be in the differential. Anything else? So metastatic disease from squamous cell primary. Anything else? Wagner's.
HPV?
Fungal infection, yeah. It could be fungal infection, could be multifocal pneumonia. Necrotizing pneumonia can give you multiple lesions, although you might expect to have more changes within the lung parenchyma surrounding these lesions. Okay. Somebody said HPV. Is that a good answer? Yes or no? Who said HPV?
I did.
Is that a good answer?
I think they cause cavitary lesions, but you would expect papillomatosis in the airways.
Do they have thin walls or thicker walls?
Thin?
Thin. Not a good answer.
Okay.
Okay? And this is a solid, one of these is solid, see that? Same patient. How do we put the findings together? What do we think this person has? What are the findings on the abdominal CT? Yeah, there's bilateral hydronephrosis. Anything else? Yeah, there's a mass in the pelvis with obstruction of the ureters. So this is a female patient. What do we think this is? Cancer of the cervix. What's the cell type of cancer of the cervix? Squamous cell, yeah. So cancer of the cervix is squamous cell that can be associated with cavitary metastases. There's also a liver lesion in this patient. Okay. All right. If you look at this X-ray, pretty much just one diagnosis should come to mind. And what is that diagnosis? Why? They have a central line, and the finding on the chest radiograph is what? Yeah, the lesions are cavitary, but also in the periphery. So the peripheral cavitary lesions is the classic finding associated with septic emboli, and this person has a central line, so there's a risk factor here for septic emboli. So septic emboli would be a good choice there. So cavitary lesions, what's our differential for that? Well, we could have septic emboli, we could have cavitary metastases, we talked about squamous cell cancer, we can have infections like TB, fungal infections, necrotizing pneumonias. There are some other more unusual things also like rheumatoid nodules, Wegener's, infarcts, even when they're non-infected, if they're large enough, might be associated with cavitation. So these are some of the things that are in our differential for cavitary lesions. Not that you need to know the numbers, but the concept is that the thicker the wall is, the higher the probability of malignancy. So the thicker the wall in the lesion, the more you're going to be concerned about malignancy when we're thinking about cavitary lesions. So this is a patient who has these rather thick-walled cavitary lesions here. This was metastatic squamous cell cancer from the head and neck, okay? So you can see that these lesions there within the lungs. This case we saw earlier, squamous cell cancer of the lung, very thick-walled. So that thick-walled lesion does increase your concern for malignancy. So septic emboli, predisposing factors, IBDA, tricuspid endocarditis, central lines, any indwelling prosthetic devices, immunocompromised patients. We look for peripheral nodules or opacities with cavitation. They predominantly at the lung bases. Some textbooks talk about the feeding vessel sign. It turns out that that's really not that helpful. So peripheral lesions, especially with cavitation, we want to think about septic emboli. Realize, though, that early septic emboli will not be cavitary. So you can still include it in your differential diagnosis if the patient has risk factors, if they're bacteremic or septic, and they have peripheral lesions. It may be early before you actually see cavitation. And then, so your classic finding, we have all these cavitary lesions. They tend to be in the periphery. Textbooks talk about the feeding vessel sign, but now with thin section CT, you can connect the vessel to any lesion, so the feeding vessel sign really is not a useful finding, for any type of lesion when we're looking at CT scans in these cases. So these can be very subtle. So, the patient shows up in the ER with infection. You look at this chest X-ray, some retrocardiac opacity, right? And really, you're hard-pressed to say that there's anything abnormal in the lung. In retrospect, you might wonder about this thing over here, but the findings are extremely subtle, especially on portable chest radiographs like we get from the emergency room on these patients. And then we do the CT scan, and we see these lesions, peripheral lesions with cavitation, okay? So this is a typical presentation of septic emboli. Many times you don't suspect it at all when you're looking at the chest radiograph, and it is not until you do the CT on that patient that you actually bring up the possibility that the patient might have septic emboli. Okay. Pulmonary infarcts, even if they're not infected, there's a patient with large PEs, there's this peripheral cavitary lesion here. If the infarct is large enough, can cavitate, so those are sterile infarcts, but those usually have to be pretty large before we actually see cavitation within those aseptic pulmonary infarcts. And then for cavitary metastases, we think of squamous cell primaries. What are the primary tumors? Well, head and neck tumors, esophagus, cervix, lung cancer, all of these can be squamous cell, all of these can metastasize to the lung, and all of these can be associated with multiple cavitary lesions. Realize, though, that adenocarcinomas might also cavitate. So even though most cases tend to be squamous cell, about 1/3 of cases of metastatic cavitary tumors can be adenocarcinoma. So it's not completely out of the question. All right, so here we have a 43-year-old woman with cough and fever. And then here's the x-ray presentation. Here's the x-ray 10 days later. So what do we see there at presentation? What do we see 10 days later? Tell me. What are the findings first?
Right upper lobe consolidation.
Yeah, so we have a lobar pneumonia there, right upper lobe consolidation. What happens 10 days later? Is it better or worse? It's worse. So there are lucencies there, by the way. Do other parts of the lung look like they're affected now?
Yes.
Yeah, the rest of the lung looks worse too, right? Looks like you have multifocal regions of consolidation. And now we have lucencies within this area. So what do you suspect is going on? So necrotizing pneumonia, so here we have cavitation. So can you provide a specific diagnosis given the findings?
Scat?
Pseudomonas or Staphylococcus
Well, why are you picking those organisms?
are associated with
Cavitation.
cavitation.
Well, they can be associated with cavitation. What's different when you look at the right upper lobe between the first image and the second image?
There's the increased lucency, which suggests cavitation.
There's cavitation. Anything else? It actually looks bigger on the second image, right? The right upper lobe looks like it's increased in size. Now do you have a specific diagnosis? So what kind of pneumonia is associated? What do we call pneumonias? So what's the term, what's the eponym for that? Whose name is attached to that type of pneumonia? Friedlander's pneumonia. That's Friedlander's pneumonia. So pneumonia that actually increases the size of a lobe is called Friedlander's pneumonia, and the organism associated with that, Klebsiella, although it can be other types of gram-negative organisms. You can see here the extensive consolidation that actually increases the size of the lobe here, and now we have cavitation here within this area of infection. It's multifocal pneumonia in this patient. So this is a patient with necrotizing pneumonia. So cavities with extensive consolidation, these are the organisms we think of: Staph, Klebsiella, Pseudomonas, anaerobes, other gram-negatives. But Klebsiella especially can be associated with what's called Friedlander's pneumonia, where the actual size of the lobe increases because of the voluminous amount of the volume of the consolidation itself. Okay. All right. The finding on this chest radiograph, or findings. Do the lungs look normal? First of all, there's a big heart, but I'll give you that. Do the lungs look normal?
Yeah, there's like peripheral consolidations.
Yeah, so it looks like we have some patchy opacities here within the lungs. Let me give you a close-up there. So do you notice anything about the opacity here? It's cavitary. So what could this be? Why do you mention that?
Because they have some shoulder, some changes.
So there are pretty extensive changes here, rheumatoid changes in the shoulder. You have high riding shoulders, you have erosion of the distal clavicle. What is this thing? That's an erosion, right? Is the disease unilateral or bilateral? Yeah, you have bilateral symmetric arthropathy with erosion of the distal clavicle. So this is a patient with long-standing rheumatoid arthritis, okay? So in that type of patient who has cavitary nodules, it's a pretty rare diagnosis, but you might consider rheumatoid nodules. So these can be associated with cavitation. So rheumatoid nodules can be associated with cavitation. And usually the rheumatoid arthritis is long established and advanced, so it's not usually, the first time you're considering rheumatoid arthritis in the patient. But the rheumatoid changes in the shoulder there should give you a clue as to what you might include on your differential diagnosis. So let's talk about rheumatoid arthritis and the manifestations of this within the chest. The most common manifestation is pleural disease, pleuritis, pleural effusion. It can also be associated with interstitial pulmonary fibrosis. Rheumatoid nodules are actually pretty rare, and then there are some other things that we can also get with rheumatoid: Kaplan's, bronchiolitis obliterans, rheumatoid vasculitis that can give you pulmonary hypertension. This is important. Although rheumatoid arthritis is more common in females, the thoracic manifestations are more common in males. Most common thoracic manifestation is pleural involvement, especially pleural effusion. So we can see pleural effusions. A sequela of that can be pleural thickening. So we might see that on chest x-rays in patients with rheumatoid arthritis. Pulmonary fibrosis is also associated with rheumatoid arthritis, and if we examine these patients with CT as opposed to chest radiograph, you'll find a higher percentage of these patients will have interstitial changes on chest CT. So even though it's a very small percentage of patients with rheumatoid who develop interstitial lung disease, rheumatoid is such a common disease that it is not unusual to run into patients with rheumatoid arthritis who have pulmonary fibrosis. So, it might be more common than to actually see pulmonary fibrosis from idiopathic pulmonary fibrosis. Again, it's going to be more common in males. And again, the arthritis is usually well established. So it can look just like, it gives you a UIP pattern. So it looks just like idiopathic pulmonary fibrosis. So we have peripheral subpleural honeycombing, these interstitial opacities. So it might look like UIP in most cases. It might also look like NSIP in some cases with more ground glass and no honeycombing. Less common patterns that you might see with rheumatoid arthritis, an organizing pneumonia pattern and bronchiolitis obliterans. So these are other patterns of interstitial lung disease that might be associated with rheumatoid arthritis. So these necrobiotic nodules from rheumatoid arthritis, so it's the same pathology that you would see in the subcutaneous tissue within these patients. It's pretty rare, less than 1% of patients, again, more common in males. If you're thinking about this, ask if the patient has subcutaneous nodules, because 80% of these patients who have rheumatoid lung nodules will have subcutaneous nodules. And again, the rheumatoid arthritis is usually well established and advanced. So we can see these nodules tend to be multiple. They can be associated with cavitation. They might have other pleural findings, and the nodules might increase or decrease in size slowly over time. So we already went over our case of these lesions there within the chest in a patient with rheumatoid arthritis, and in this case, they were cavitary, in this case of rheumatoid arthritis. Now, Kaplan syndrome, so this occurs associated with co-workers pneumoconiosis or silicosis. So these are miners, so they work in coal mines, and if they have rheumatoid arthritis, the association or the exposure to the silica or the coal can actually accelerate the formation of those rheumatoid nodules within the lungs, and that's called Kaplan syndrome. So they might have a combination of pneumoconiosis and rheumatoid nodules. It's more common in the United Kingdom, but so these are essentially rheumatoid nodules in patients who are coal miners. So that's Kaplan syndrome. They may occur as crops of lesions. They may grow. They might be associated with calcification or cavitation. And some of these patients might have a background pattern of silicosis or coal workers pneumoconiosis. But to call it Kaplan syndrome, you need that history of working in coal mines. Vasculitis and pulmonary hypertension. So this is also rare, but patients with rheumatoid arthritis might develop a pulmonary vasculitis and pulmonary artery hypertension, and it looks like pulmonary hypertension from every other cause, very large central pulmonary arteries. And so there's really nothing specific about the appearance of this, except that the patient has underlying rheumatoid arthritis. Okay. If I tell you that this patient has renal failure and the CT looks like this, what are things that we might consider here?
GPA?
So what is that GPA stands for?
Granulomatous polyangiitis.
So granulomatosis with polyangiitis, or it used to be called Wegener, so that's a granulomatous vasculitis. And so it's a vasculitis of the small vessels, and it actually results in infarcts in the lung, which is what causes the cavitation. This also affects the kidneys, so these patients can have renal failure and glomerulonephritis. Now, there is an entity called limited Wegener's, which occurs in about 10% of these patients, and it only affects the lung without renal or systemic involvement. So you might be the first person to actually suggest this if you're reading a CT scan that shows these cavitary lesions in a patient who doesn't happen to have renal disease. It can also involve the upper respiratory tract in these patients. So diagnosis, things that help in making the diagnosis are elevated ankle levels, and most of these patients will have elevated C ankle levels, and they might have upper respiratory tract symptoms like sinusitis, rhinitis, or cough, or even hemoptysis. So we might see focal opacities, can be associated with cavitation. You might have nodular masses. Cavitation occurs in up to 40% of cases, so that's why we include this in our differential of cavitary lesions. Sometimes they might be peripheral in wedge shape, like infarcts, and the cavities result from ischemic necrosis because of the vasculitis. Some patients, a small percentage, can develop pulmonary hemorrhage, so this is a cause of pulmonary hemorrhage, in which case they will have consolidations. And you can also have thickening of the trachea and bronchial stenosis, because it can also affect the cartilage of the airways, so granulomatosis with polyangiitis. So what is this X-ray showing us? What do we call this? Yeah, so this is the crescent sign. Okay. So what gives us this?
Aspergilloma.
Yeah, so anything that cavitates might give you the crescent sign, but the air crescent sign itself is associated with what form of aspergillosis?
Fungus ball.
Well, a fungus ball might look like this, that's true, but technically the air crescent sign, that term is associated with what form of aspergillosis? Not the saprophytic form, no. Invasive aspergillosis, yeah, although people will use it interchangeably, because the appearance looks so similar. So the air crescent sign is when we get peripheral. Now, this is the technical term. I mean, the really technical definition of this is if we get a peripheral region of cavitation within a lesion. So it's peripheral cavitation within a lesion that gives us the air crescent sign. Now, it turns out anything, anything that cavitates, if it happens to cavitate peripherally, might give you the air crescent sign. But this type of peripheral cavitation, if you have a lesion with peripheral cavitation, is particularly associated with invasive aspergillosis. The peripheral lucency associated with the fungus ball is called what? Monod sign, or Monod sign, right? So they're technically two different, although people tend to use them interchangeably, especially air crescent sign with fungus balls. Okay, so there is, in terms of the actual origin of these signs, there is a difference between the meanings of those two, although this tends to be used interchangeably with the Monod sign. But anything that gives you peripheral cavitation can give you the air crescent sign. So we can see it with invasive aspergillosis, we can see it with necrotizing infections, we can see it with these other things. Anything that cavitates, if it happens to cavitate in the periphery, might give you an air crescent sign, but particularly invasive aspergillosis. All right. What do we see here? Yeah, so here you have this large cavity, and then you have this dependent nodule. So what is this going to be?
That's,
Yeah, this is the fungus ball, right? So here you have a dependent fungus ball within a large cavity, right? So that's a fungus ball. And how can you prove it's a fungus ball? Well, if you move the patient around, you can actually watch it move within the cavity, right? So this is the saprophytic form of aspergillosis. This is a fungus ball. So the Monod sign is when you have peripheral lucency because of a fungus ball within a cavity. So what's the difference? The difference is here, the cavity comes first and the fungus ball grows in the cavity, as opposed to the air crescent sign where you have an opacity first that cavitates in the periphery, so the cavitation comes after the opacity, right? So that's the difference between those two. So this is the Monod sign when you have aspergilloma growing within a cavity. Now, of course, they can look on a plain film just like an air crescent sign. Okay? So if I tell you that this patient is neutropenic after chemotherapy for lymphoma, and we happen to do a CT and it looks like this, what are we thinking of? Yeah, so here you're thinking about invasive aspergillosis. You have these ill-defined nodular lesions, especially if there's some ground glass around them, and that ground glass comes from hemorrhage around these lesions. If I tell you this person has a history of asthma and the CT looks like this, what's the finding on the CT? Yeah, so here we have bronchiectasis, particularly in a central distribution, right? So here, what do we think of? So here you think of allergic bronchopulmonary aspergillosis. So that's another form of aspergillosis. This tends to affect asthmatics. This gives them mucus plugging, and it can give them bronchiectasis. So bronchiectasis in asthmatics, especially associated with mucus plugging, there we think of allergic bronchopulmonary aspergillosis. So the different forms of aspergillosis infection to be familiar with, there is the aspergilloma, there's invasive aspergillosis, we can have angioinvasive aspergillosis, which we see in neutropenic patients. We can also have airway invasive aspergillosis that tends to affect patients with AIDS. There's semi-invasive aspergillosis, which we'll also discuss a little bit about, and then allergic bronchopulmonary aspergillosis, which tends to affect asthmatic patients. So the fungus ball grows in a pre-existing cavity. The underlying diseases for those pre-existing cavities, sarcoid, bullous emphysema, TB, those are the most common causes in the United States. So the cavity comes first, then the fungus ball grows in the cavity. Now the fungus actually lines the whole cavity, and so there can be inflammatory change around it. And hemoptysis is a complication of this because of the inflammatory change around this cavity and neovascularization that can occur. And sometimes that can be life-threatening because the blood vessels can be arterial vessels under arterial pressure. Okay, so these fungus balls, the formation is not always so benign. You can prove it's a fungus ball if we change the patient's position and it actually moves around. So you see the decubitus position, this thing falls down to the dependent region of the cavity. So we have a mobile round density within a cavity. The Monod sign is that peripheral lucency, sometimes used interchangeably with the air crescent sign. Common to have adjacent pleural thickening, and the cavity may look thickened. Again, remember that the fungus actually lines the whole cavity, even though we see that big fungus ball within the cavity itself. So here we have a lesion with a ground glass halo. And this is 3 days later. So what's going on here? Yeah, so this is the formation of the air crescent, and you would suspect this patient has invasive aspergillosis, right? So this is angioinvasive aspergillosis. So it starts out as a nodular lesion or nodular mass-like consolidation with peripheral ground glass halo representing hemorrhage around the lesion. And then the patients start to develop the air crescent or the peripheral cavitation, which tends to coincide with what? Improvement of the white count. These patients are neutropenic, and as the neutropenia gets better, then they tend to mount this cavitary reaction to the infection. So this tends to coincide with the white count going back up in these patients. All right. So angioinvasive aspergillosis, these are usually immunosuppressed patients who are neutropenic. The fungus invades the blood vessels, resulting in thrombosis and infarction. So it's the hemorrhage around the lesion that gives us the ground glass halo on the CT scan, and then goes on to form the peripheral cavitation or the air crescents in these patients. So it starts out as a mass-like consolidation, and then over time, especially when the white count starts to get better, they develop this peripheral region of cavitation within the lesion. That is the classic air crescent sign of invasive aspergillosis. So we'll see the halo sign first, and this is when you need to suggest this. So if you have a neutropenic patient who has mass-like consolidations or nodules, especially with ground glass surrounding them, you want to suggest invasive aspergillosis so they can think about that diagnosis, because you're going to see this before you actually see the air crescent sign. So this warrants then antifungal therapy for these patients, even before you see the air crescent sign within these patients. So you might be the first one to suggest it based on the appearance of the CT. Okay. So here's a nice example of the evolution of this at presentation. We have a nodule, looks more like a mass, and then over time, you start to get the peripheral cavitation, the air crescent in these patients. So that's invasive aspergillosis. So airway invasive aspergillosis, this tends to affect patients with AIDS. So this grows within the airways, especially the peripheral airways, gives you central lobular opacities, tree and bud opacities, and it invades the airways found deep to the basement membrane. All right. So this is associated with peribronchiolar consolidations and smaller peripheral nodular opacities because it affects the smaller airways. That's airway invasive aspergillosis. Semi-invasive aspergillosis is similar to invasive aspergillosis, only it has a much longer protracted time course with semi-invasive aspergillosis. So these patients tend to have more chronic underlying disease that makes them susceptible, like a COPD or diabetes. It makes them susceptible to chronic infection with aspergillosis. So these are underlying conditions that might make the patient susceptible. They might also have underlying lung damage that might also make them susceptible to chronic infection with aspergillosis. And so they can develop cavitary lesions, bronchiectasis, fibrosis, especially in an upper lobe distribution, but it is a much longer time course than invasive aspergillosis. So the infection goes on for weeks, months. It's a very chronic infection that can progress very slowly with semi-invasive aspergillosis. So here's an example of somebody with, so give me a differential for, this appearance on a CT. What could this be? What's your differential diagnosis for this appearance on a CT scan? Well, what's the first thing you're going to mention? Yeah, the first thing you're going to mention is tuberculosis, right? So you have upper lobe fibrotic disease, we have bronchiectasis, maybe some cavity formation. The hilum is elevated, there's volume loss here, right? You see the bronchus is pulled up. So those are typical manifestations of tuberculosis, right? So certainly tuberculosis is going to be the first thing you're going to mention. What else might be in a differential diagnosis? What else what other infection can look like tuberculosis and give you upper lobe fibrotic disease? What?
Other fungal infections,
Histoplasmosis, right, can do that, so certainly fungal infections. But more common than that around here, it almost has TB in its name, atypical mycobacterial infection, right? So atypical mycobacterial infection also has to be in your differential diagnosis. So we have tuberculosis, we have atypical mycobacterial infection, we have fungal infections like histoplasmosis, and what other fungal infection? The topic of this point of the lecture is, yeah. So this is in this case, this was semi-invasive aspergillosis, right? This was chronic aspergillosis infection. So semi-invasive aspergillosis can also look like tuberculosis. So if you have a patient who has these kind of changes that looks like TB, but the cultures keep coming back negative and they don't think it's TB, well, what else could it be? Well, atypical mycobacterial fungal infection like histoplasmosis, but semi-invasive aspergillosis could also do this. Is this a good appearance for sarcoid? Because that's another disease that can give you upper lobe fibrotic change. Is this a good appearance for sarcoid? Yes or no? No. The answer is no. Why is it not a good appearance for sarcoid?
You expect more symmetric?
Yes, sarcoid tends to be more symmetric. Okay, so if you have more symmetric changes within the upper lobe fibrotic disease, that's more typical of sarcoid. But sarcoid is also in the differential for upper lobe fibrotic disease. Okay, but it tends to be more symmetric than this. Right? Now, allergic bronchopulmonary aspergillosis. This affects patients with asthma, but can also affect patients with cystic fibrosis. So these patients have asthma, they can have peripheral consolidations, blood eosinophilia, allergy to Aspergillus antigen. And so the Aspergillus grows in these mycelial plugs, which causes then these thickened plugs in the airways, mucus plugging of airways, bronchiectasis, and especially central, although it can occur anywhere within the lungs. So the radiographic findings, we talk about the toothpaste shadow or the finger and glove sign. These are signs of mucoid impaction. They can have bronchiectasis, perihilar or upper lungs. They can have consolidations, atelectasis, upper lung fibrosis. So here you have this branching tubular opacity. So when we see like branching tubular opacities like that, especially more towards the central region of the lung, we think of mucoid impaction. This is the finger and glove sign. Right? So in an asthmatic with this, then we might think of allergic bronchopulmonary aspergillosis. Another feature of this is that the attenuation tends to be high even on non-contrast CT. So it can be because of calcium or metallic ions within the mucus, but high attenuation mucoid impaction is also associated with allergic bronchopulmonary aspergillosis. And if you have an asthmatic patient with bronchiectasis and mucus plugging, we want to include that in our differential diagnosis. What's the finding here? Well, the obvious finding is we have this big what? You have this large cavitary lesion. What looks peculiar about it? Yeah, there's this opacity that is layering out, right, in the dependent portion of the cavity, right? So what is this going to be? Yeah, so this is the appearance of a ruptured echinococcal cyst within the lungs. In the liver, these things calcify. They don't calcify in the lungs, right? So this is a echinococcal infection within the lungs. So this is called the floating lily sign. When this thing ruptures, then the contents of it kind of float within this layer of fluid, within this ruptured echinococcal cyst. So it's kind of a pathognomonic appearance of a ruptured echinococcal cyst. So this is Hydatid disease caused by tapeworms. So humans are the accidental host. Dogs are the primary host. So it's endemic in parts of the world where we raise sheep. Okay. The life cycle, I am not going to go through the life cycle because it is so disgusting. I will leave that to you to study on your own. But basically, humans are accidental hosts, and it can affect the liver. More commonly, we see it affecting the liver. But we can also it can affect the heart. You can find these things in the heart, even in the pulmonary arteries. But we can also see them within the lungs. So classically, the description, 3 layers of the walls. There's the pericyst, which is the fibrotic capsule of the host. You have the exocyst or the ectocyst, which is the outer laminated membrane, and then the endocyst or the intergerminal layer. And when the cyst is not ruptured, it is just a large fluid collection. But when it ruptures, air gets in between these layers of the cyst wall, and it collapses, and it the contents fall down and float around there within the dependent portion of this cavity. So that is the appearance of a ruptured echinococcal cyst. So that can give you an air crescent sign, okay? Sometimes the cyst can rupture into the lung, bronchial tree, or pleural space. And then when the contents kind of float around within the dependent portion, it's called the water lily sign or camelot sign, where it's just kind of floating around in the dependent portion as the cyst crumbles. Before it ruptures, it's actually a round, well-defined lesion, like that. That's what it looks like. And this will be fluid attenuation on CT. It's a fluid attenuation lesion. But when it ruptures, then you'll get these different layers floating around in the dependent portion of the cyst. Okay? What is this called? First of all, describe it. How would you describe this? Yeah, well, you have would you call it, well, why not? It's thin-walled, air-containing cystic lesion, right? So there's a term for this. Pneumatocyte, right. So round, thin-walled, air-containing lesion. So that is called a pneumatocyte. What are causes of pneumatocytes?
Trauma.
So trauma can cause pneumatocyte. What infection is associated with pneumatocyte formation?
PCP,
What infection?
pneumocystis,
Pneumocystis, yes. What other infection?
Staff.
Staph, right. Any infection can do it, but particularly staph, pneumocystis, is so we do medicine. You mentioned trauma, right? With trauma, it tends to be a pulmonary laceration, and in the resolving phase, you can be left with a pneumatocyte. In this particular case, this patient has pneumatocytes associated with ground glass opacities in the lungs, right? So your first thought here is going to be what? Pneumocystis pneumonia, right? So this is pneumocystis pneumonia that can be associated with ground glass consolidations and pneumatocyte formation. So what a pneumatocyte is a thin-walled air collection. This occurs from air getting to the interstitium of the lung. The air gets into the interstitium and gives you this round, thin-walled lesion. Over time, this can resorb. This can resolve on its own. So it's like a check valve mechanism where the air gets in, can't get out, but over time, that can resorb and resolve on its own. So that's what we call the pneumatocyte. Causes, staph, other bacterial infections, barotrauma, you can see it in patients who are intubated with high pressures, they can develop pneumatocytes. Blunt trauma from laceration of the lung parenchyma, you get a hematoma, and then when that resolves, you can be left with a pneumatocyte, and over time, that can also resolve. Pneumocystis in children, interestingly, hydrocarbon ingestion can also be associated with pneumatocyte formation. So if I tell you that this is a trauma patient, what do we call these? What are these called? These are pulmonary lacerations. So these are tears within the lung, and all of this is hemorrhage in the lung because of the pulmonary laceration. So you can see what happens over time as this resolves. This can convert into a pneumatocyte with the thin-walled lesion there. It's an air collection in the interstitium, and then over time that will also resolve on its own. So it can be a sequela of pulmonary lacerations. The finding in this patient is what? We don't see it? No? Let's go back. This thing right here. See? Okay, so what do we see on the CT scan? Yeah, I wouldn't call it thick, but we do have a cyst here. Is that the only lesion in the lung parenchyma?
In the trachea.
Yeah, we also have lesions in the airway. Yeah, so this has more than one lesion, and then there's also another thin-walled lesion here. So what is this called?
HPV.
Well, what's the term for this? So multiple lesions within the airways, right? Tracheobronchial papillomatosis caused by HPV, okay? And then here's virtual bronchoscopy to show you what these lesions look like there in the airways. You have these multiple papillary lesions along the airway walls. So same patient, What follow-up study is this? What kind of study is this?
That's it.
This is a PET CT. What's the finding?
Malignancy.
What?
Is it secondary malignancy?
What malignancy is that?
Squamous cell.
This is squamous cell cancer, right? So that is the complication of these lesions, is transformation to squamous cell cancer, okay? So, respiratory papillomatosis caused by HPV, used to be more common in children as exposure to the virus during passage through the infected birth canal, but now we see it in adults with HIV. So these patients can develop these papillary lesions in the airway, thin-walled cystic lesions in the lung, and then over time they can transform into squamous cell cancer. So that is the complication of these lesions. All right. So that is our discussion of multiple nodules and cavitary lesions. Any questions?